Now I'm going to talk about GLP-1 for diabetes and obesity. But today I'm going to talk about the GLP-1 beyond diabetes and obesity. But we still start with diabetes and obesity. We know GLP-1 affects weight, enhance insulin secretion, inhibit glucagon release, and delay gastric empty, and enhancing satiety. That's the main GLP-1 effect. Yeah. And the GLP-1 on NMC reduction is really profound. It's a 2023 meta-analysis. Feeding exon to zeptide reduced A1C by 2%, and 10 milligram reduced by around 1.8%. Semaglutide 2 milligram reduced A1C around 1.6%, and 1 milligram reduced by 1.5%. And it surpassed 2 studies. The everything reduction even more profound. 15 milligrams of zeptide reduced A1C by 2.3%, and even 5 milligrams of zeptide can reduce A1C by 3%. And in this study, they used 1 milligram of semaglutide reduced A1C by 1.8%. The weight loss also very significant. And based on 2023 meta-analysis, a 50 milligram tirzepatide reduced weight by 4%. These are in diabetes patients. And also adding the ground reduced a lot of antioxidants. 2 milligrams semaglutide reduced by 8%, and the semaglutide reduced by 6%. But they have recently published true data. These are real-time renal community data of round trigger. So anybody wanted to do study, actually we can look into this huge database called True Measure. So in non-diabetic patients, tirzepatide can reduce the weight close to 18%. And semaglutide around 10%. In diabetic patients, because they reduce the weight around 14%, and semaglutide reduce weight around 6%. However, in the Symposium study, the weight loss even more profound. The 15 milligram tirzepatide reduce weight around 20%. And even 5 milligram can reduce weight around 15%. And in the stage 2 study, semaglutide is 2.4 milligram. Also, there are 13% of patients can reach weight loss over 20%. Now we're going to look at GLP-1 beyond weight loss and A1C reduction. GLP-1 receptor actually widely present in all the major organs and tissues. And they're present in the brain and the different area of the brain, liver, stomach, intestine, kidney, heart, pancreas. And surprisingly, actually the density is very high in the lung. So beyond obesity and diabetes, so GLP-1 actually has been approved to reduce the cardiovascular disease events in non-diabetic patients. So these for patients obesity or overweight, but they also have high risk for cardiovascular disease. These days in the select trial. So these trials do have over 17,000 patients, around 48 weeks or months. So these studies, they compare with semaglutide and placebo. The primary cardiovascular composite endpoint reduced by 20%. The cardiovascular all mortality reduced by around 15%, and the heart failure composite endpoint reduced by 18%. The deaths from overall mortality reduced by 19%. And the protection mechanism for cardiovascular disease we also believe to be could be direct or indirect. Direct effects might improve the endothelial function or anti-inflammatory effect. The indirect effect could be through the reduce the weight and reduce the blood pressure and better sugar control, and also reduce the LDL. So for the mechanism for lowering blood pressure, we report that GLP-1 respondent to have also some natriuresis also have effect on the endothelial cells and vasodilation and reduce the sympathetic nerve activity and also reduce active of the RAS system. And certainly also might go through because the weight loss and also could be, generally speaking, reduce the food intake and resulted in the salt reduction intake. And GLP-1 on that also actually found most effect on the triglycerides. That's very classic. And produce phosphorylated triglycerides called macron, LDL, and retinase. And for the LDL cholesterol reduction, around 6.4 milligram. Total cholesterol reduced 20 milligram. And also reduce FLD, reduce dense LDL, and increase the size HLDL. And on the HDL, effect is better. And the question is, should we use GLP-1 on those people with severely elevated triglycerides? So the standard answer is no, as we know both might cause pancreatitis. But however, in select patients, I still use that. But sometimes I can't discuss the risk. But you believe or not, as I said, in these patients, some of the patients, their triglycerides can be reduced very significant. So from high risk actually to low risk. And in this study, this select study also stand over the COVID time. Actually, they found this paper just published last month, and they found no cardiovascular deaths, often reduced, but very significantly during the pandemic time. And this actually was contributed by the COVID. So the COVID death mortality risk is reduced by 34%. That's very interesting. And the goal on GLP-1 on chronic kidney disease, Dr. McGee already talked about on the first slide. So this actually mimic the source of evidence. So we actually see GLP-1 also has little protective effects. And when this is the first slide, also I'm not going to in detail that we already talked about. So, but the major kidney disease events reduced by 24%. That's a very significant. And the deaths from 80-cause mortality also reduced by 20%. These patients, they already have high EGFR or high UACR, proteinuria, or both. And the possible mechanism could be direct effect or indirect effect. The direct effect might affect on the intrarenal, the hemodynamics, and through the prevent oxidative effect, excluding damage or reduce hyperfusion. That's very possible. And the indirect effect is going to go through the sugar control, blood pressure control, and weight loss, and also possibly reduce the receptor function for advanced digestion and credit. The GLP-1 also on MASH, so quickly as we call NASH. So that's the, I think that will be approved right now, if not, but I think that's the next thing we can count on to help those people with MASH or NASH. And these we still believe maybe those mediated by the weight loss. And and also polycystic ovarian syndrome. It's actually very common. People around the world encounter us, and with weight issues and other issues, depression inside their hair growth, hair loss. So these will be also a great treatment. And I have patients after we treated, they get pregnancy. So that's the thing we actually need to warn the patient. Be careful if you don't want to. So that's on GCIS. And also another difficult thing to treat, something called reactive hypoglycemia. We actually have lots of people, kind of refer to us. We actually don't like these patients, because it's really hard to deal with. And so I actually, started using GLP-1 of these people. Surprisingly, they actually really effective. So contraindicated, retweeted. So these patients, before GLP-1, they get out of the car, they got down, and after treatment, actually sugar much more stable, and even have a little piety, and they can see follow no sugar. It's very interesting. Okay, so another big thing is obstructive sleep apnea. So these are actually also very important. All the people come to us, I know the kind patient will be kind of not good at it, or we know we find to have is fatigue. So a lot of patients come to us fatigue because they have sleep apnea, and we have CPAP. It's good to treat these patients, but unfortunately, I think that with half of the patients they come off really poor. And now these GLP-1 actually found to be very effective in treating sleep apnea. So these very recent study published just in June 2024, and they selected these very severe patients with apnea index greater than kind of 50. So above 5 is abnormal, above 30 is severe. So these patients are very severe. After the chosen kind of treatment case where their AHI reduced more than half. So they're from very, very severe to moderate. So how I want to get those people not on CPAP, and try to those you're already on CPAP. And these seems like are related to weight loss, I think. So because in 2016, they already have a study on sleep apnea used liraglutide, but the weight loss in that found is much moderate at 6%, and they reduce the AHI index by 12. So we get it's significant, but not as profound as using diet. So I think the most likely because our weight loss difference. So let's look at GLP-1 on the lung. As I say, the GLP-1 receptor actually very widely spread present in the lung. And so GLP-1 actually also was found really effective on treating or reduce the exacerbation for COPD. So these most effective could be actually from reduce the inflammatory cells, reduce inflammatory response, and also decrease the protease levels in the lung tissue, improve the airway mucus, homeostasis, and reduce airway remodeling, and promote the synthesis of alpha-1 antitrypsin and increase the alpha-1 antitrypsin levels. So that's very interesting. And also asthma. So for those people currently diabetes with asthma, if we treat it with GLP-1, their chance to exacerbation reduce significantly. So these can be also go through by reducing the airway inflammation, obstruction, and the fibrosis. And also interstitial ovary fibrosis. In many studies, they show GLP-1 actually reduce fibrosis in animal models reduced by these various chemical agents. And a very common topic right now on Alzheimer's disease. So GLP-1 they have shown potential neuroprotective effects in animal models, and actually right now they have huge studies going on. And also Parkinson's disease is another neurodegenerative disease. It's hard to deal with. Guess what? GLP-1 might actually restore calming levels, inhibit dopaminergic arousal, and attenuate neurodegenerative and alleviate motor and non-motor symptoms. And as I said, these are possible mechanisms could go through the insulin signaling or prevent neurodegenerative and improve or restore dopamine levels. And guess what? Also, GLP-1 actually has a direct effect on depression. So these it's hard to say. It's good through, because people overweight, coming to control diabetes and enough, they actually get some educated control and they getting better. But also at the same time, I saw that all the people actually have increased risk for suicide. So as the suicide, if on risk, I think is very low. But other than that, anti-depression medications we use can also kind of increase the mental of suicide. So for some people, they're being depressed or pre-top or the risk effect. So and also they found actually GLP-1, I feel use might increase the kind of anxiety, but the quality use actually they can't see any effect on anxiety, but actually improve the depression. Okay, and the alcohol, the substance dependence actually difficult to deal with. But guess what? You actually help people stay away from alcohol. So these actually decrease the spontaneous inhibitory forces and actually get the current from the central amygdala and influencing the cortex. And also a lot of studies they talking about GLP-1 on other substance dependence, okay, stimulus, obvious, and other indicative effects. So very interesting. And guess what? We all afraid cancer. And GLP-1, taking GLP-1 was added to significant reductions in the risk of developing gallbladder cancer, pancreatic cancers, liver cancer, ovarian cancer, colorectal cancer, esophageal cancer, endometrial cancer, and kidney cancer, meningeal, and multiple myeloma. So that's the, quite, what don't you say? Sounds like MC, but we're not yet. So right now, FDA is still only approved for ARA disease and with these cardiovascular events in high-risk patients. And as I said, we're not indicated for other conditions I talked about in clinical, but we use it for MBL. And also the you being, kind of careful with evaluate as the indications on the monitor side that the judge is the next. Thank you very much.
So this is a little off topics, but I wanted to get your opinion here. Like, what I have seen in clinical practice is just a huge difference genetically, it seems like, and how people respond to therapies. So it's like profound. And you're like looking at all of this now. Did you find anything about that? Like genetic reason became, because little trials, like they all give us like the overview, but then I've had people who were on 10 clicks of Ozempic, and then they used to be on 2 high cadence of insulin per day, nothing else changed, and they're on no insulin now, and I just can't understand like what the difference that I see between people. The huge bell curve is.
Yeah, so the question is, why we see clinically so different people response to this GLP-1. And I saw it also. Some people, we use very low dose and then we response alone. And some people, you climb up to 2.1 Ozempic with appetite 50%. So these are not so effective. I didn't see people that doing genetic study kind of try to do it, but I think that will be, interesting thing. I think it's smart people, popular someplace. Maybe let's do it.
Studies, genetic studies, looking at various genotypes relative to the wild type. Some of them are incredibly get a very, very good response, and some have a counterproductive result. And I think that ultimately what we see, what is in clinical practice, is all going to be relegated to whether father genetics show. And so you could predict on the front end, just like you do in your culture, when you get results back there.
That's another thing that's about now to get. But either like the actually, I have seen people opposite, doing such as even for, I have one patient. They take it, my appetite increase. Yeah, and then we see often some people get diarrhea, some people constipation. I don't know what for a while. Why get diarrhea? But that's what happened. So yeah, so that's why eating I do. We start with another thing is it be interesting. I use semaglutide, preservative, and that's the most too common. And GLP-1, and I use one, if not really well, I switch another. And sometimes go one different, very interesting. Kind of hard to say why. And for the side effect also, some people have side effects to Zephyr, but not the same thing. It's because missing education. I think not just GLP-1 or molecules they have different compounding substances might have some effect. So kind of hard to say. That's what I did.
You're not surprised, I guess, with the use of GLP-1s for reactive hypoglycemia because there's got delayed glycemia, which is going to decrease the absorption of
now
so it makes a lot of sense. And it also makes sense to you try to let form and just reduce insulin levels as well. I don't try this, but it does like earth to
Yeah, that's the thinking aspect. Yeah, there's goddamn is this thing. Yeah, these things, the differences you see could be like some patients put them on several they have like really bad anemia, like they like something spend on eating without eating really pressure. So I previously put them on shepherd. It's not really better. I mean, the blues are better, but they're not much more than like 30 things to do the blood-brain barrier at the crossing molecule. You just have to.
Do you Did you ask if it does cross the?
Yes.
It does.
Yes.
Yeah.
Not the dress or.
Uh huh.
Oh well.
They do. It is my understanding. Yeah.